Good day, sir. Good day, everyone. My name is Odufo Grace Olutoyin, and I'll be speaking of neuropharmacology, explaining the mechanism of action, uses, and side effects of anxiety-reducing drugs. Anxiety disorders, including generalized anxiety disorders (GAD), panic disorders, social anxiety disorders, and specific phobias, are among the most prevalent mental health conditions globally, affecting millions of individuals. Pharmacological interventions, commonly referred to as anxiolytics, are frequently employed to manage anxiety symptoms. These drugs work through various mechanisms to modulate neurotransmitter activities in the brain. These drugs are classified based on their pharmacological mechanisms, which target various neurotransmitter systems or physiological pathways to alleviate anxiety symptoms. And the major classes include: we have the benzodiazepines, where we have the short-acting, the midazolam, trazolam. We have the intermediate acting as well, the lorazepam, the alprazolam, then the long acting, the diazepam and clonazepam. We also have the selective serotonin reuptake inhibitors. Examples are the fluoxetine, the sertraline, paroxetine, escitalopram, citalopram. Also the serotonin non-epinephrine reuptake inhibitors. Examples, we have the venlafaxine, duloxetine, desvenlafaxine. We have the azapirons too. Examples, we have buspirons. The beta blockers, we have propranolol, atenolol. The antihistamines, we have the hydrazine, diphenhydramine. There are also miscellaneous agents like the pregabalin, the gabapentin, and tricyclic antidepressants. The mechanism of actions of these drugs. For benzodiazepines, benzodiazepines are a class of psychoactive drugs widely used for their rapid anxiolytic, sedative, anticonvulsant, and muscle relaxant properties. They inhibit the primary inhibitory neurotransmitter in the CNS, which is the GABA, the gamma-aminobutyric acid. And by doing this, they reduce neuronal excitability. This neuronal excitability refers to the ability of the neurons, that is the brain cells, to become excited and activated, thereby transmitting signals. So once they reduce the neuronal excitability, they produce a relaxing and calming effect. The selective serotonin reuptake inhibitors, they work by serotonin is a key neurotransmitter involved in mood regulation, emotional processing, and anxiety modulation. So SSRIs, which is the selective serotonin reuptake inhibitors, they work by selectively inhibiting the reuptake of serotonin into presynaptic neuron, thereby increasing serotonin availability in the synaptic cleft. So the SSRI enhance serotonergic neurotransmission, which is thought to contribute to the anxiolytic effect. The SSRI works by increasing serotonin level in the brain, enhancing serotonin signaling, and reducing anxiety symptoms. We also have the serotonin non-epinephrine reuptake inhibitors. This inhibits the reuptake of both serotonin and non-epinephrine by targeting the serotonin transporter, the SET, and the non-epinephrine transporter, the NET. So this dual action, that is the both action, increases the synaptic availability of both neurotransmitters, which are critical for mood and arousal regulation. The combined modulation of serotonin and norepinephrine enhance emotional regulation and reduce physiological symptoms of anxiety, such as hyperarousal and excessive worry. These serotonin norepinephrine reuptake inhibitors, they are similar to SSRI in efficacy and side effect profile, but may cause additional effects like hypertension due to the non-epinephrine activity. So we also have buspirone, which is buspirone is classified as an azapirone. It acts as a partial agonist at serotonin receptor, modulating serotonin signaling. It does not interact with gamma aminobutyric acid system, which is the primary target of the benzodiazepine, but instead it modulates monoamine neurotransmitter system. An example of this monoamine neurotransmitters are the dopamine, the serotonin, and norepinephrine. But this buspirone particularly modulates the serotonin, but it also exhibits mild effects on dopamine system, acting as a partial agonist at dopamine D2 receptor, particularly in the stratum and prefrontal cortex. This action is less pronounced than its serotonergic effect, but may contribute to its anxiolytic profile. We also have the beta blockers. We said that the beta blockers, also known as beta adrenergic receptor antagonists, they are primarily used to treat cardiovascular conditions such as hypertension and arrhythmias. They are also employed off-label for the management of anxiety, that is, they are being used to treat anxiety but is not specifically approved for it. They are just used as off-label for the management of this anxiety. So unlike selective serotonin, unlike the SSRIs, the SNRIs, or the buspirone, beta blockers do not directly modulate mood or central nervous system neurotransmitter system. Instead, their anxiolytic effects are mediated through the peripheral blockade of the sympathetic nervous system, which reduce the physiological manifestation of anxiety. That is, beta blockers, they work to reduce anxiety by blocking the body physical stress response, like the fast heartbeat or sweating. They do not directly affect the brain. So some therapeutic example, by blocking B1 receptor in the heart, beta blockers reduce heart rate and cardiac output, counteracting the palpitation often experienced during anxiety. Blockade of beta 2 receptor in skeletal muscles, it will reduce tremor, a common somatic symptom of anxiety, particularly in performance anxiety. By attenuating sympathetic activation, beta blockers decrease excessive sweating and vasodilation, which are mediated by beta 2 receptors. So we move to the tricyclic antidepressants, the TCAs. The TCAs are a class of medications initially developed for the treatment of depression, but widely recognized for their efficacy in managing anxiety disorders, including the generalized anxiety disorder, the panic disorder, and obsessive compulsive disorder. Although TCAs have largely been superseded by the SSRIs and the SNRIs due to their side effect profile, they remain relevant for treatment-resistant case or specific anxiety disorder. The anxiolytic effects of TCAs are primarily mediated through their modulation of monoamine neurotransmitters. I said examples of this monoamine neurotransmitter, the dopamine, serotonin, norepinephrine. But these TCAs, they work on the serotonin and norepinephrine, and their downstream effects on neurocycles and neuroplasticity. TCAs such as imipramine, amitriptyline, and clomipramine are named for their three-ring chemical structure. TCA block the serotonin transporter set and non-epinephrine transporter net, increasing the synaptic concentration of serotonin and non-epinephrine. The relative potency for serotonin versus non-epinephrine reuptake inhibition varies amongst TCAs. For example, the clomipramine is more selective for serotonin reuptake inhibition and is particularly effective for OCD and anxiety disorder with obsessive features. Imipramine and amitriptyline have balanced effects on serotonin and non-epinephrine, making them effective for GAD, that's the generalized and the panic disorders. This dual reuptake inhibition enhance monoaminergic neurotransmission which is critical for regulating mood, arousal, and anxiety related neurocircuits. The TCAs interact with multiple receptor systems, some of which may contribute to the anxiolytic effect. TCAs block histamine H1 receptor, leading to sedation, which can reduce arousal and promote sleep in patients with anxiety-related insomnia. The sedative effect is particularly pronounced with amitriptyline and dozepine. Anticholinergic effect may indirectly modulate anxiety by affecting arousal and cognitive processing. Through these effects are more associated with side effects like dry mouth and constipation. So blockade of alpha-1 receptor may reduce sympathetic arousal, contributing to anxiolysis, though it can also cause orthostatic hypotension. While these receptors interactions are primarily responsible for side effects, their sedative and arousal dampening effects may enhance the anxiolytic profile of certain species in specific patient population. So the therapeutic uses of
Wait. So here now, what's an example of TCA now she mentioned here? Do you now see why they normally add it as they call it? They tell you that's sleep medicine. Doctor added, pharmacist gave me. I want it today, even though they're not supposed to be asking for it. Do you not see why they ask for it? Because of what does it do? It does something that make it possible. She said it here. She said what amitriptyline does. So what does it do? I'm not asking. I'm asking us here. Please, I want us to listen to what she's saying. Please, continue.
Okay. The therapeutic uses of anxiety-reducing drugs for the selective serotonin reuptake inhibitors. It is used for the generalized anxiety disorder. SSRIs such as the sertraline, escitalopram, and paroxetine. They are first-line treatments for GAD, that's generalized anxiety disorder, due to their efficacy in reducing chronic worry and somatic symptoms. They are well tolerated and suitable for long-term use. They are also used for panic disorders, such as the sertraline and fluoxetine. They are effective in reducing the frequency and severity of panic attack and anticipatory anxiety. That prevent over benzodiazepines due to their non-addictive nature. They are also used in treating post-traumatic stress disorder, the PTSD. Sertraline and paroxetine are FDA approved for PTSD, reducing intrusive thoughts, hyperarousal, and avoidance behavior. The other uses, SSRI are sometimes used off-label for specific phobias or anxiety associated with depression or medical conditions. So the SNRIs, the serotonin non-epinephrine reuptake inhibitors, they are also used for generalized anxiety disorder. The duloxetine and venlafaxine are FDA approved for GAD, effectively reducing worry and somatic symptoms. They are particularly useful for patients with co-occurring depression or physical symptoms. These SNRIs are also used for panic disorders. They are used for social anxiety disorders. They are also used for PTSD. The buspirone, which is under the azapirons, they are also used for generalized anxiety disorders. It's a FDA approved for GAD, effectively reducing chronic worry and mild somatic symptoms. It is particularly suitable for patients with a history of substance abuse due to its non-addictive profile. The beta blockers, the propranolol is widely used off-label for situational or performance anxiety, that is public speaking, musical performance, effectively reducing physical symptoms such as palpitation and trembling. It is typically administered as needed. The other uses are they may be used off-label to manage somatic symptoms of anxiety in GAD or SAD, particularly in patients with prominent cardiovascular symptoms. They are employed in PTSD to reduce hyperarousal, though evidence is limited. The tricyclic antidepressants. These are used for panic disorder. The imipramine is effective in reducing panic attack and anticipatory anxiety, often used in treatment-resistant cases. They are also used for generalized anxiety disorders. Imipramine and amitriptyline are effective for generalized anxiety disorder, particularly in patients with recurring depression or insomnia due to their sedative properties. OCD, that is the obsessive compulsive disorder. Clomipramine is a first-line treatment for OCD with strong efficacy due to its potent serotonin reuptake inhibitor. The tricyclic antidepressants are also used for PTSD. TCAs like amitriptyline are used off-label for PTSD, particularly for hyperarousal and sleep disturbance. Other uses can be used off-label for SAD or chronic pain syndromes with anxiety. The advantage is that effective for treatment-resistant anxiety or an OCD, sedative properties beneficial for insomnia. The benzodiazepines now. These benzodiazepines are used for short-term relief of severe or acute anxiety symptoms across disorders, e.g. the GAD, the panic disorder, due to their rapid onset. They are also used for panic disorder. The alprazolam and clonazepam are effective for acute panic attack and are sometimes used to speech therapy while awaiting SSRI or SNRI effects. Generalized, they are also used for generalized anxiety disorders. They are used for social anxiety disorder, and other uses that they are used off-label for insomnia, procedural anxiety, or as adjuncts in PTSD or OCD. Other anxiety reducing drugs, the pregabalin. FDA approved pregabalin for GAD in some countries, effective for somatic and psychological symptoms. They are also used off-label for social anxiety disorder and PTSD. Hydroxyzine, they are used for GAD and situational anxiety, particularly in patients requiring sedation without dependence risk. The monoamine oxidase inhibitors, they are effective for social anxiety disorder and panic disorder in treatment-resistant cases, but they are rarely used due to dietary restriction and side effects. So the clinical consideration for first-line treatment, the SSRIs and SNRIs are first-line for most anxiety disorder due to their efficacy, safety, and suitability for long-term use. The TCAs, buspirone and pregabalin are used for second-line treatment for treatment of resistant cases for specific disorder. Then the short-term use, the benzodiazepines, beta blockers, and hydroxyzine are used for acute or situational anxiety, often as adjuncts to SSRIs and SNRIs. So the side effects and adverse effects, adverse reaction of these drugs. For selective serotonin reuptake, it causes gastrointestinal disturbance like the nausea, diarrhea, and decrease in appetite. It also causes sexual dysfunction, decrease in libido, delayed ejaculation. Also, its effect on central nervous system, it causes insomnia, headache, fatigue, jittiness. The adverse reaction is that initial worsening of anxiety. Acute serotonin increase can exacerbate anxiety or cause agitation in the first 1 to 2 weeks, necessitating low starting dose. It can cause serotonin syndrome, where both serious This occurs with overdose of drug interaction, presenting with agitation, hyperthermia, and muscle rigidity. For serotonin norepinephrine reuptake, the common side effects are the effect on GIT now. We also have the nausea, constipation, and dry mouth. Its effect on CNS causes insomnia, headache, dizziness, and fatigue. Sexual dysfunction is also similar to SSRI, that it causes decreased libido and orgasmic dysfunction. The buspirone, common side effect of buspirone is effect on CNS, causes dizziness, headache, and lightheadedness. The effect on the GIT, it causes nausea and mild abdominal discomfort. Then the beta blockers, common side effects on cardiovascular, the effect on cardiovascular system, it causes bradycardia, hypotension, and fatigue. On the effect on CNS, it causes dizziness, lightheadedness, and mild sedation. The effect on GIT, nausea or mild abdominal discomfort. Then tricyclic, the clinical consideration for beta blockers. So beta blockers are well tolerated for as needed use in performance anxiety, but require caution in patients with respiratory or cardiovascular comorbidity. The TCAs, the common side effect of TCAs causes dry mouth, constipation, blood vision, and urinary retention. Its histaminic effect causes sedation and weight gain. The benzodiazepines, common side effects of benzodiazepines, its effect on CNS, it causes sedation, drowsiness, and cognitive impairment. Causes fatigue, general weakness, or lethargy, especially with higher dose. Then other anxiety reducing drugs, the pregabalin, common side effects, it causes dizziness, weight gain, and peripheral edema. The adverse reaction is withdrawal symptoms with abstract discontinuation. The hydroxyzine, common effect is sedation, dry mouth, headache due to histaminic effects. So in conclusion, anxiety reducing drugs encompasses a diverse range of pharmacological classes, each with distinct mechanism of action, clinical application, and side effect profile. The benzodiazepines provide rapid relief for acute anxiety but carry risks of dependence, making them suitable for short-term use. SSRIs and SNRIs are preferred for chronic anxiety disorder due to the efficacy and non-addictive nature, though they require weeks to achieve therapeutic effect. Buspirone offers a non-sedative alternative for GAD, while beta blockers and antihistamines address specific situational or mild anxiety symptoms. Clinicians must weigh the benefits against potential side effects, considering patient-specific factors such as comorbidity, risk of dependence, and treatment goals. Ongoing research continues to refine anxiolytic therapies, aiming to optimize efficacy and minimize adverse reaction. The classification of anxiety drugs reflects their diverse pharmacological mechanism, ranging from GABA enhancement to serotonin modulation and peripheral symptoms control. Each class is suited to specific clinical scenarios, with SSRIs and SNRIs are first line for chronic anxiety, benzodiazepines for acute relief, and other adjuncts or alternatives. Selection depends on efficacy, side effect profiles, patient comorbidity, and risk of dependence, emphasizing the need for individual treatment plan. Benzodiazepines reduce anxiety by allosterically enhancing GABA-A receptor function, increasing chloride conduction and hyperpolarizing neurons, particularly in anxiety-related regions. Their action on specific receptors ensures targeted anxiolytic effects, while the rapid onset makes them ideal for acute scenarios. However, the mechanism also explains risks like tolerance and dependence. necessitating judicious ones. Understanding this mechanism is critical for optimizing the therapeutic application while minimizing adverse effects. The TCAs exert anxiolytic effects primarily through inhibition of serotonin and norepinephrine reuptake, leading to increased monoamine availability and subsequent neuroadaptive changes such as photoreceptors desensitization and receptor downregulation. These changes modulate anxiety-related neurocircuits, including the prefrontal cortex, amygdala, and hippocampus, and promote neuroplasticity. Secondary effects such as histamine and alpha-adrenergic receptor antagonists may enhance anxiolytic by reducing arousal and promoting sedation. While effective for GAD, panic disorder, and OCD, TCAs are limited by their side effects profile and cardiotoxicity, making them second-line treatment in most cases. Thank you.
Thank you. Thank you. Thank you. Thank you. Thank you. Thank you. Any question? Any question? No question. I asked for code. You just
I told her
ignored me. No question. Please, can someone help me record? This will soon go on. No question. All right. Thank you very much. Please, still on this reference. I'm not. Please, that reference should be in alphabetic. Please, very important. I also noticed it in your own work.
I'm sorry, what do you want this thing to
One. No, I'll rule that one. No, I will use. Okay. Thank you very much.